Most clinicians treat tinnitus like a single problem, a frustrating noise in the ears to be dulled, distracted from, or ignored. Here's the uncomfortable truth. Tinnitus is a symptom, not a diagnosis. And unless someone finds the right diagnosis first, treatment is often guesswork. Today, I'm going to share 5 clinician-validated secrets from an ENT who spent more than 25 years treating and researching tinnitus. Practical, evidence-informed truths that change how you and your doctor should approach that ringing, buzzing, or whooshing you hear. Dr. Michael Golenhofen's work shows that roughly 3 broad subtypes explain about 80% of tinnitus cases. And once you know which one fits, the path forward becomes a lot clearer. Before we begin, if this is the kind of information you've been looking for, type yes in the comments so we know you want more clinically practical guidance like this. Secret number 1, the diagnostic truth. Most tinnitus falls into 3 main subtypes, and diagnosis is often simpler than you think. The single most important clinical insight Dr. Michael emphasizes is that tinnitus isn't a single disease. In many clinics, the reflex is to offer a generic plan, counseling, a trial of a hearing aid, or a prescription to help sleep, without a focused attempt to find the cause. That's where things go wrong. A focused history and a few targeted tests will usually point to one of 3 dominant subtypes: cortical or attention-driven tinnitus, somatosensory tinnitus related to the jaw and neck, and cochlear tinnitus related to hearing loss. Dr. Michael has found these 3 categories explain most of what he sees in practice. Put simply, cortical tinnitus is about how the brain pays attention to an internal sound. Somatosensory tinnitus is modulated by jaw or neck inputs. Cochlear tinnitus is tied to damage or dysfunction in the inner ear. Each has different red flags, different immediate questions to ask, and different next steps. Knowing this framework narrows the differential and prevents a scattershot approach to treatment. What to listen for as a patient? Ask your clinicians these core questions. When did the sound start? Suddenly or gradually? Is it in one ear or both? Do you have noticeable hearing loss or difficulty understanding speech in noise? Does jaw movement, chewing, or turning your neck change the sound? Did it begin after dental work, neck injury, or a period of severe stress? These 5 points will often point you in a direction. What clinicians should do first? Take a focused, targeted history with those 5 questions and perform a basic audiogram. If the audiogram shows measurable hearing loss and the tinnitus matches that side, think cochlear first. If the audiogram is normal, the onset was sudden and unilateral, and the sound changes with jaw or neck movement, consider somatosensory causes and pursue a TMJ-focused exam and dental imaging as appropriate.
If onset follows a period of acute stress, or the patient reports that the sound seems louder when they are anxious or when they focus on it, prioritize counseling and strategies to reduce attention on the sound. Practical, immediate action for patients. If you haven't had a recent hearing test, request one and tell your clinician the 5 questions above. Even a basic audiogram will change the care plan. For clinicians, add those 5 history questions to your routine intake for any patient reporting tinnitus. A short, structured history reduces unnecessary testing and avoids reflexive prescribing. A short example will bring this to life. A 52-year-old patient comes in with a high-pitched tone they first noticed after a weekend of teeth grinding and a dental crown replacement. They do not report hearing loss on routine conversation. On careful history, they say the tone is louder when they clench their jaw or when they roll their head to the right. An audiogram is essentially normal. In this scenario, the somatosensory mechanism jumps to the top of the list. The management pathway is different than if that same patient had symmetric, gradual hearing loss and a lifelong history of noisy occupations. Mini hook before Secret 2. Secret 2 explains a commonly missed cause of tinnitus that often responds to simple, targeted evaluation, and where the wrong first treatment can do more harm than good. Secret 2. Somatosensory tinnitus, TMJ neck. Often overlooked, often diagnosable, and sometimes treatable through interdisciplinary care. Somatosensory tinnitus is one of the most underappreciated pieces of the puzzle. When tinnitus is driven by somatosensory input, the sound can be altered or modulated by movements of the jaw, pressure on the neck, or specific positions. Typical clues include a sudden unilateral high-pitched tinnitus, an absence of measurable hearing loss on audiometry, and a clear temporal relationship to dental work, jaw pain, or neck trauma. Patients may report that the noise changes when they chew, yawn, or clench their teeth. Others say the sound varies after a chiropractic adjustment or neck strain. Why this matters? If the tinnitus is somatosensory in origin and you treat it as though it were cochlear, for example giving systemic steroids reflexively, you may delay the correct evaluation and expose the patient to ineffective or unnecessary interventions. Conversely, when recognized early, a targeted pathway can involve dental assessments, imaging like an orthopantomogram when indicated, and referral to appropriate musculoskeletal specialists. Patient red flags to watch for. Sudden one-sided tinnitus with little or no hearing loss reported, clear jaw pain or TMJ symptoms, recent dental procedures or neck injury. If you have these, bring them to your clinician's attention explicitly.
Clinician cues and immediate steps. When a patient's tinnitus is unilateral, of sudden onset, and audiometry is normal or shows no corresponding cochlear lesion, perform a focused TMJ and cervical spine exam. Ask whether jaw movement modulates the sound. Test simple jaw opening and closing, lateral excursions, and palpate for joint tenderness or muscular trigger points. If you find modulation and no cochlear signs, consider imaging, such as an orthopantomogram, to evaluate dental and TMJ anatomy, and refer to a dentist with TMJ experience or a specialist in orofacial pain. If musculoskeletal dysfunction is suspected, physical therapy, osteopathic or chiropractic evaluation, or an interdisciplinary dental approach may be the most direct route. Practical, immediate action for patients. If your tinnitus began after dental work or you notice jaw pain and sound modulation, tell your clinician and ask specifically, could this be related to my TMJ or neck? Would you order a dental x-ray or refer me to a dentist who treats TMJ? That one sentence can alter the workup you receive. Practical, immediate step for clinicians. Include jaw and neck modulation checks in your tinnitus exam. If modulation is present and audiometry doesn't show cochlear pathology, avoid reflexively prescribing steroids. Instead, communicate a clear referral. This looks somatosensory. I'll request dental imaging and refer you to orofacial pain physiotherapy. If any hearing deterioration or new cochlear signs appear, return urgently. A clinical vignette. A 37-year-old woman wakes one morning with loud ringing in her left ear after sleeping on her side with her jaw supported on a folded arm. She reports no hearing difficulty in conversation, but notices the sound intensifies when she opens her mouth wide to yawn. Audiometry reveals normal thresholds. Her clinician orders a panoramic dental x-ray and refers her to a dentist with TMJ expertise. Within weeks, targeted dental and physical therapy approaches aimed at reducing jaw clenching produced measurable improvements in the perceived loudness. The management here was precise because the history pointed away from cochlear disease and toward a somatosensory driver. Important caution: referral, not scope expansion. If you are not a dental or musculoskeletal specialist, do not attempt invasive dental or orthopedic interventions yourself. Screen, identify the possibility, and expedite the correct referral. For the patient, that means insist on a targeted evaluation rather than a blanket, try this medication answer. Mini hook before secret number 3. Secret number 3 explains why worry and attention itself can amplify tinnitus and why trying to fix the sound with medicine alone is often the wrong first move. Secret number 3. Stress, attention, and the cortical subtype, how the brain's filter turns up the volume. One of the most powerful but least intuitive secrets is that tinnitus often becomes a problem not because of the sound itself, but because of how the brain attends to it. Dr. Michael often frames this as the brain's filter or gate. Under normal conditions, the brain filters out internal background noise, so we're not constantly aware of spontaneous neural firing in the auditory pathways. Under stress, anxiety, or hypervigilance, that filter lowers. The brain stops ignoring the background hum, and the internal noise becomes conscious, intrusive, and distressing. A simple analogy works. Imagine a tea kettle on a low simmer in a busy kitchen. When you're focused on cooking, the kettle's hiss blends into the background. If suddenly you are alone with the kettle in a quiet room, or if someone points at it and says, "Listen to that sound," you'll notice it immediately. And the more you listen, the louder and more important it feels. The sound itself hasn't changed, but your attention has. For many people with tinnitus, that shift in attention is the primary driver of suffering. What this means for treatment: when the cortical or attention-driven mechanism predominates, counseling and behavioral approaches should be the primary treatment. Defocusing strategies, deliberately reducing attention to the sound, building habits that re-establish a healthy filter, and addressing the stressors that keep the brain on high alert can substantially reduce the perceived burden even when the tinnitus sound persists. Cognitive behavioral therapy, CBT, and structured counseling are evidence-informed options for this subtype and should not be presented as optional add-ons, but as core elements of care. Patient signs that this is the dominant problem: tinnitus that began or worsened after a significant life stressor, marked anxiety about the sound, sleep disruption primarily because of worry about tinnitus, and the subjective sense that attention makes the sound worse. Patients often report that when they are relaxed or absorbed in an activity, the sound fades into the background. Clinician actions: assess for mood disorder, anxiety, sleep disturbance, and the degree of catastrophic thinking about tinnitus. Offer or refer for counseling and CBT early. Practical handhold strategies include teaching defocusing exercises, recommending consistent sleep hygiene, and encouraging gradual re-engagement in previously avoided activities.
When medication is considered, frame it as symptomatic support for sleep or anxiety, not as a cure for tinnitus, and discuss risks and benefits. In immediate action for patients, ask your clinician for a referral to a therapist experienced in tinnitus-specific CBT, or for structured counseling that includes defocusing techniques.
You can also begin simple behavioral steps now. Create a bedtime routine that reduces evening hypervigilance. Use low-level background sound at night if silence amplifies the noise. And practice brief focus-shifting exercises. For example, spend 5 minutes intentionally engaging in a sensory task that requires concentration. Reading with a pen to follow lines, a tactile hobby like knitting, or a simple puzzle. These aren't magic, they're ways to retrain attention. An immediate action for clinicians. Incorporate a screening for anxiety, sleep disturbance, and catastrophic tinnitus beliefs in your initial visit. If the screening is positive, prioritize referral for CBT or counseling and explain to the patient why behavioral strategies are central to their recovery. A patient vignette. A man in his mid-40s develops constant tinnitus shortly after a period of job loss and financial stress. His audiogram is unremarkable. He becomes preoccupied with the sound, checks it repeatedly, and avoids quiet because the ringing feels overwhelming. Through CBT focused on defocusing and reappraisal, coupled with sleep support and gradual behavioral activation, he learns to reduce the intensity of his reaction. The sound remains, but it occupies far less of his mental space. That outcome results from changing attention and threat perception, not from silencing the auditory signal itself. A practical clinician checklist that helps across all subtypes. Ask these 5 history questions at the first encounter: onset timing, sudden or gradual; laterality, one side or both; hearing loss, subjective or objective; jaw or neck symptoms or triggers; recent dental work or neck injury; and psychosocial stressors. These questions will often separate cortical, somatosensory, and cochlear paths quickly. Before we move on, here's a short patient-friendly sentence you can print and carry to your clinician. I have had, describe sound, in my right, left, or both ears since date. It began after dental work, neck strain, stress, noise exposure. The sound changes when I clench, chew, turn my neck, and I notice no hearing trouble, difficulty understanding speech, worse with stress. That compact paragraph helps direct the clinic toward a focused evaluation. Mini hook before secret number 4. Secret number 4 covers what happens when tinnitus is tied directly to hearing loss, and why timely action matters in acute cases. Many patients and clinicians underestimate the urgency in certain situations. Secret number 4, cochlear tinnitus, when the ear itself is the source and biomedical interventions play their strongest role. Cochlear tinnitus is the subtype most closely linked to measurable hearing loss. When there is damage or dysfunction in the inner ear's hair cells or neural transmission, spontaneous neural activity can be perceived as tinnitus.
In these cases, the loudness and distress of the sound often correlate with the degree of hearing impairment, and interventions that restore or compensate for hearing can meaningfully reduce the perceived tinnitus. For patients who have progressive or noise-induced hearing loss, modern hearing rehabilitation, well-fitted hearing aids, sometimes paired with sound therapy, and for those with profound loss, cochlear implants, can significantly reduce tinnitus burden. The mechanism is straightforward. Restoring auditory input reduces the brain's need to amplify internal signals, thereby decreasing the relative prominence of tinnitus. But there is an important nuance that distinguishes routine cochlear tinnitus from an acute cochlear event. When tinnitus begins suddenly and accompanies a new loss of hearing in one ear, that may represent an acute cochlear injury. In those cases, interventions such as systemic steroids, or in very selected circumstances, and within a narrow time window, hyperbaric oxygen may be considered. Timely ENT evaluation is essential. Dr. Michael is adamant. Any patient with sudden unilateral hearing loss or sudden severe tinnitus should be evaluated by ENT within 72 hours, because early treatment may change outcomes. Here's where the pathway and decision-making differ. Chronic cochlear damage with long-standing hearing loss will rarely benefit from acute medical therapy. Instead, rehabilitation is the priority. Acute cochlear injury demands urgent assessment and discussion of possible acute interventions. The difference is the timing and the presence of objective hearing loss on audiometry. What patients should watch for: sudden reduction in hearing on one side, new severe tinnitus on one side, fullness or pressure in the ear, dizziness. These are red flags. If you experience sudden changes, seek urgent ENT evaluation. What clinicians should do now: perform urgent audiometry, and if there is a new unilateral sensory neural hearing loss, initiate ENT referral within the critical window. Don't reflexively treat every case of unilateral tinnitus with steroids unless audiometric and clinical findings suggest cochlear involvement. A clinical snapshot.
A 60-year-old woman notices she cannot hear out of her right ear upon waking, with a loud new winging. This is an emergency situation where rapid assessment can influence whether acute medical therapies are considered. In contrast, a 65-year-old man with decades of noise exposure, who has stable bilateral high-frequency hearing loss and chronic tinnitus, is approached with hearing rehabilitation strategies rather than acute medical intervention. And yet, and this is where practice frequently stumbles, many patients are told to learn to live with it after a single poorly targeted visit. That advice is harmful when the cause is treatable, or when urgent ENT assessment could have altered the course.
We're now at a crucial juncture in this roadmap. We've laid out the diagnostic framework and covered 3 of the 5 secrets that guide targeted care. The 4th secret begins to open the door on biomedical options and timing. The 5th will address medications, supplements, and how to advocate for proper care without being misled by overhyped promises. But before those, it's important to pause and recognize how these pieces fit together in everyday clinic flow. Imagine a patient coming in for the first time. The clinician asks the 5 core history questions, performs an audiogram, screens for jaw and neck modulation, and assesses stress and sleep. Within a single, focused visit, the clinician often narrows the working diagnosis to one of the 3 main subtypes, or recognizes a combination that requires interdisciplinary management. That focus avoids 2 common pitfalls. The first is underinvestigation, where a treatable somatosensory cause is missed. The second is overtreatment, where invasive or medical therapies are applied without clear indication. To make this concrete for both patients and clinicians, here are immediate, practical steps you can take right now. If you are a patient experiencing tinnitus and you haven't had a recent hearing test, request one and present the brief 1-paragraph history we discussed. If you have jaw pain or your tinnitus changes with jaw motion, ask for a dental assessment and an orthopantomogram. If your tinnitus began after a major stressor and your audiogram is normal, ask for a referral for counseling or CBT focused on defocusing. And if your tinnitus appears simultaneously with sudden hearing loss, present to ENT urgently for assessment within the 72-hour window. For clinicians, the checklist is equally actionable. Add the 5 history questions to your intake, perform audiometry early, test for jaw and neck modulation, prioritize counseling for cortical cases, order dental imaging when the history suggests somatosensory involvement, and refer urgently for any new unilateral sensory neural hearing loss. This diagnostic-first approach changes the downstream treatment strategy and improves patient outcomes. At this midpoint, we've built the foundation, a diagnostic triage that identifies cortical, somatosensory, and cochlear drivers, practical red flags for patients, and concrete clinician actions. The remaining secrets focus on the therapeutic landscape and on how to navigate medications, supplements, and patient advocacy resources effectively. One of the most common questions I hear is, what actually helps? Pills, supplements, hearing aids, therapy? The answer is nuanced and depends on the subtype and timing, and that is exactly what secret number 5 will unpack. But before that deep dive, there's an important clinical reality. Many patients have mixed presentations.
For example, someone with mild high-frequency hearing loss, a cochlear substrate, can still become hypervigilant and develop a cortical overlay that amplifies distress. Similarly, a mild somatosensory contribution can coexist with cochlear damage. Recognizing and treating all relevant components, not just one, is how progress is made. In practice, that requires clear communication among ENT, audiology, dental, and mental health professionals. One short, practical tool clinicians can use immediately is a scripted referral line that patients can hand to their providers. Here is a concise, patient-facing paragraph that captures the essential facts without overstepping scope. I developed, describe sound, in my right, left, both ears, on date. The sound is constant, intermittent, and changes, doesn't change, with jaw movement or neck position. I do not have trouble hearing speech, and my last hearing test was on date, if known. Please evaluate for possible cochlear, somatosensory, TMJ neck, or cortical contributors, and advise on targeted referrals or imaging as needed. This single paragraph helps focus the next clinician visit and reduces ambiguity. We've covered a lot of ground so far: the 3 subtype framework, the distinctive clues for somatosensory tinnitus, and the central role of attention and counseling in cortical cases, plus an introduction to cochlear tinnitus and the urgency surrounding acute unilateral events. That framework is the backbone of appropriate triage and treatment. The next section will explore the therapeutic toolkit in more depth, what hearing aids and implants can do when acute biomedical interventions are considered, and how medications and supplements fit, safely and realistically, into a comprehensive plan. Before we go there, pause and reflect on where your situation most likely fits within the 3 subtype model.
That clarity guides the right questions for your clinician and the right referrals for your care. Secret number 4, cochlear tinnitus, when restoring sound helps the brain stop over-amplifying internal noise. When the ear itself is the main problem, the clinical goal shifts from chasing the phantom sound to restoring or compensating for missing input. In cochlear tinnitus, damage to hair cells or to synaptic connections reduces the normal external signals reaching the brain. The auditory system compensates by turning up internal gain, and that internal activity is what the patient perceives as tinnitus. Bringing back reliable external input reduces the brain's need to boost internal noise, and that's why hearing rehabilitation is often the most effective tool for this subtype. Red flags and what to ask as a patient. Do you struggle to hear conversations, especially in noisy places? Did the sound appear gradually over months or years, alongside difficulty with speech understanding? Do you have a history of loud noise exposure, ototoxic medications, or ear infections?
If you answer yes to these, prioritize a full audiological assessment. If your audiogram shows measurable sensory neural loss, matching the side and frequencies of your tinnitus, consider rehabilitation as the next step. What clinicians should do now: obtain an accurate audiogram, include speech discrimination testing, and when available, extended high-frequency testing and otoacoustic emissions to assess cochlear function. Counsel patients that well-fitted hearing aids are often the first-line rehabilitative option for symptomatic relief in cochlear tinnitus. Hearing aids can reintroduce environmental sounds and improve signal-to-noise ratio, which reduces central gain. For patients with severe to profound loss who meet candidacy, cochlear implantation is another option that frequently reduces tinnitus perception, sometimes dramatically. But be explicit, these are rehabilitative measures. They often lessen the perceived loudness and bother, but they do not promise complete elimination. Acute cochlear events, urgency, and the narrow therapeutic window. Perhaps the single most important practice point in ENT care is recognizing which tinnitus presentations are urgent. Sudden sensory neural hearing loss, often accompanied by new unilateral tinnitus, earfulness, and sometimes vertigo, is a time-sensitive condition. If objective testing confirms a new unilateral sensory neural hearing loss, ENT evaluation within 72 hours is recommended, because early systemic corticosteroid therapy and, in selected cases, hyperbaric oxygen have been associated with better outcomes. Those interventions are medical and time-dependent. They belong to ENT management and require informed consent and appropriate workup. Clinical nuance: do not reflexively treat unilateral tinnitus with steroids unless audiometry and clinical assessment indicate cochlear involvement. Many patients with sudden unilateral tinnitus have a somatosensory driver or functional overlay without objective cochlear loss. Steroids will not help those presentations and may expose patients to unnecessary risks. The correct pathway is prompt audiometry and, when indicated, urgent ENT assessment. Practical patient action: if your tinnitus began together with a sudden drop in hearing, seek ENT or urgent audiology within 72 hours. Say explicitly, "My hearing dropped and I have new tinnitus on this side." That phrase often gets immediate attention and appropriate triage. Practical clinician action: same day or very prompt audiometry for suspected sudden loss. If confirmed, discuss the risks and potential benefits of early medical therapy and refer for ENT consultation within the critical window. What hearing devices actually do: realistic expectations. Hearing aids are not a magic bullet. Many patients experience meaningful reduction in tinnitus perception, improved ability to follow conversation, and reduced listening fatigue.
Modern devices can also include sound enrichment programs or tinnitus masking modules, which some patients find helpful. Expect variation. Degree of benefit depends on the pattern of hearing loss, consistent device use, proper fitting and counseling, and concurrent management of attention or somatosensory drivers. For clinicians, coordinate with experienced audiologists who provide counseling as part of the fitting process. Counseling is a major determinant of successful tinnitus outcomes with amplification. When cochlear implants are considered, for those with severe to profound bilateral hearing loss, cochlear implantation can provide both speech rehabilitation and tinnitus suppression in many cases. Candidacy follows established audiologic and cochlear implant program criteria. Discuss realistic outcomes, risks, and the rehabilitation commitment. Emphasize that tinnitus reduction is a potential benefit, but not a guaranteed primary outcome. The primary indication remains hearing restoration. Sound therapy and auditory enrichment. Sound therapy covers a range of approaches, from simple environmental sound enrichment to devices that deliver customized sound programs. Evidence is mixed. Sound enrichment is most helpful when used as part of a structured program that includes counseling and behavioral strategies. For patients with cochlear tinnitus, recommending steady, low-level ambient sound, fans, quiet nature sounds, or hearing aid amplification can reduce the perceived prominence of tinnitus, especially in quiet environments.
Clinicians should set realistic expectations. Sound therapy helps with habituation and reduces distress for many, but it is not universally effective as a standalone cure. Secret number 5, medications, supplements, and the care pathway. What helps, what's adjunctive, and how to get the right referrals. The bottom line on drugs and supplements is this: there are very few disease-modifying pharmaceuticals for chronic tinnitus. Most medications are used to treat comorbid symptoms, anxiety, depression, insomnia, or severe autonomic arousal that amplify tinnitus's impact. That said, there are circumstances where symptomatic pharmacological therapy plays a constructive role. Medications, symptomatic role, not cure. Short-term use of medications that target sleep or anxiety can improve quality of life and reduce tinnitus-related distress while patients engage with behavioral therapies. For example, sleep aids or cautious use of anxiolytics during acute distress may restore sleep and reduce hypervigilance, which indirectly frees cognitive resources from constantly monitoring the sound. Antidepressants may be appropriate when comorbid depression or generalized anxiety disorder is present. Importantly, medication should be individualized, with side effects and interactions discussed.
Avoid framing drugs as primary tinnitus cures. Present them as tools to stabilize mood and sleep so that CBT, counseling, hearing rehabilitation, or somatosensory interventions can be effective. Supplements, adjuncts with limited evidence. You'll hear about many supplements for tinnitus. A few, like magnesium and certain serotonin precursors referenced in clinical conversations, have been considered as adjuncts. Evidence is limited and inconsistent. More importantly, supplements are not without risk or interactions. Always discuss with a clinician and review current medications before starting anything new. Present supplements as potential adjuncts that may help some individuals, but are not replacements for evidence-based assessment and treatment. What not to do. Avoid unproven protocols or off-label polymerized regimens promoted as definitive cures. If you read dramatic testimonials online, compare them to the controlled studies, and remember that single-case claims do not equal evidence. Encourage patients to be skeptical of guarantees and to choose providers who explain uncertainty, risks, and alternatives. How to advocate for proper care, the triage and referral pathway. One of the most empowering skills a patient can learn is to present a focused history that steers clinicians to the right pathway. We already suggested a one-paragraph history for the clinic visit. Here's how to use it to get referrals. Clearly state the onset, laterality, modulation by jaw or neck motion, and presence or absence of hearing difficulty. Then ask a focused question. Based on this history, would you evaluate for cochlear causes with an audiogram, assess TMJ or neck modulation, or refer me to counseling for attention-based management? That simple request forces a diagnostic-first approach instead of the all-too-common try-this-pill response. Tinnitus and patient advocacy tools. Digital triage tools like Tinnitus are designed to bridge initial patient symptoms and specialist evaluation by standardizing history taking and giving patients clear templates to carry to providers. Use them as an adjunct. They do not replace clinical assessment, but they can make your visit more productive. A concise printed or digital referral paragraph handed to the clinician saves time and ensures the important diagnostic clues are heard. For clinicians, encouraging patients to use standardized triage forms reduces variability in intake and improves targeted referrals. Practical patient-facing referral language, one paragraph template to use at appointments. I developed Describe Sound in my right, left, or both ears on date. The sound is constant or intermittent and changes or doesn't change with jaw movement or neck position. I do or do not notice hearing difficulty, and my last hearing test was on date, if known. Please evaluate for possible cochlear, somatosensory, TMJ or neck, or cortical contributors and advise on targeted referrals or imaging as appropriate.
Carry this sentence on your phone or printed page and hand it to your clinician at check-in. It changes the conversation from vague to diagnostic. Tests and referrals clinicians should consider. Most tinnitus workups can be efficiently triaged with a targeted history and a short battery of tests. Useful initial investigations include a diagnostic audiogram with speech discrimination tests, tympanometry and otoscopy to exclude conductive pathology, otoacoustic emissions when cochlear outer hair cell function assessment is helpful, orthopantomogram or panoramic dental X-ray when somatosensory features point to the TMJ or dentition, cervical spine and TMJ clinical exam, palpation for trigger points, and assessment of jaw movement modulation. Urgent imaging, MRI-CT, when red flags appear. For example, asymmetric severe sensory neural hearing loss, focal neurologic signs, or pulsatile tinnitus suggestive of vascular pathology. Use imaging judiciously. Reserve MRI when clinical or audiometric clues indicate central pathology or retrocochlear lesions may be present. Red flags that demand expedited ENT or specialist referral. Make these visible. Sudden unilateral hearing loss,
severe asymmetric sensory neural hearing loss, new pulsatile tinnitus synchronous with heartbeat, focal neurologic deficits, or rapidly progressive symptoms. In those scenarios, prompt workup and possible urgent interventions are warranted. Putting it together, practical triage flow for clinicians. A brief, reproducible intake improves outcomes. Here's a clinician workflow to adopt. 1. Ask the 5 core history questions: onset, sudden/gradual, laterality, hearing difficulty, jaw/neck symptoms or triggers, and recent dental or neck injury. Screen for major stressors. 2. Perform otoscopy and diagnostic audiometry with speech testing. 3. If audiogram shows a new unilateral sensory neural loss, arrange urgent ENT assessment within 72 hours. 4. If audiogram is normal and jaw/neck modulation is present, perform TMJ/cervical exam, consider orthopantomogram, and refer to dental/oral facial pain or musculoskeletal specialists. 5. If audiogram normal and history points to stress-driven tinnitus, prioritize referral for CBT/structured counseling and address sleep and anxiety. 6. Coordinate referrals and document the focused one-paragraph history for receiving providers to expedite correct specialty evaluation. An illustrative mixed case and clinical reasoning. Mixed presentations are common. A patient may have mild high-frequency hearing loss, a cochlear substrate, and then experience a stressful life event that intensifies their attention to the sound. In such cases, a hybrid approach is needed: hearing rehabilitation to address the cochlear deficit, combined with counseling to reduce attention and distress.
Explain to patients that benefits often accumulate when multiple domains are treated together. Audiologic support reduces the signal deficit, while counseling reduces the brain's over-attention to the residual sound. Practical phrases clinicians can use with patients. These short scripts guide conversations toward diagnostic clarity and realistic hope. We need to find the most likely driver. Is this likely cochlear, somatosensory, or attention-driven? The answer changes the next test and the referral. If your hearing dropped suddenly with the tinnitus, we need to evaluate urgently because early treatment can matter. I'm not suggesting this will vanish overnight, but we can make a plan that addresses your hearing, your jaw or neck if needed, and how your brain is responding to the sound. Common pitfalls to avoid. Reassuring is good, but dismissing is not. Saying "learn to live with it" without a targeted assessment is a disservice. Conversely, reflexively ordering high-cost imaging or prescribing steroids without diagnostic evidence of cochlear involvement is also harmful. The diagnostic-first approach avoids both extremes. Quick clinician checklist to overlay on screen: 5 questions to ask every tinnitus patient. When did the sound start? Sudden or gradual? Is it in 1 year or both? Do you have hearing difficulty, especially understanding speech and noise? Does jaw movement, chewing, or neck position change the sound? Did it begin after dental work, neck trauma, or a major stressor? Red flag on-screen text suggestions, patient-facing. Sudden unilateral tinnitus/hearing loss. Seek ENT now. Sound tied to jaw/neck movement. Ask about TMJ and dental evaluation. Severe anxiety, sleep loss, or catastrophic thinking. Ask for counseling/CBT referral. A final clinical vignette that ties the secrets together. A 49-year-old teacher develops bilateral high-frequency tinnitus over months, struggles to hear students in noisy classrooms, and becomes anxious about never being able to teach effectively. Audiology shows moderate high-frequency sensory neural loss. She is fitted with hearing aids and receives counseling for defocusing strategies. Over several months, her listening confidence returns. Tinnitus is perceived as less intrusive, and she sleeps better. Contrast that with a 34-year-old who wakes with unilateral sharp tinnitus after a dental extraction and notices the sound changes when she chews. Her audiogram is normal. Properly triaged, she receives dental evaluation and targeted musculoskeletal therapy, and her symptoms improve. These cases show that matching the treatment to the driver, cochlear rehabilitation for measurable hearing loss, dental/physical therapy for somatosensory triggers, and counseling for attention-related distress, is the clinical secret to progress. Summary: the 5 clinician-validated secrets in 1 paragraph each. 1.
Diagnostic primacy. Most tinnitus falls into 3 main subtypes: cortical, somatosensory, and cochlear, and focused history plus audiometry answers most triage questions. 2. Somatosensory is common and often missed. Sudden unilateral tinnitus with jaw and neck modulation points to TMJ neck drivers. Refer for dental imaging and musculoskeletal care rather than reflexive steroids. 3. Cortical, attention-driven tinnitus responds best to counseling and defocusing. Changing attention, addressing anxiety and sleep, and CBT are central treatments. 4. Cochlear tinnitus often benefits from hearing rehabilitation. Hearing aids and, when indicated, cochlear implants reduce central gain. Acute unilateral loss is an ENT emergency. 5. Medications and supplements are adjuncts. Drugs mainly treat sleep and anxiety. Supplements may help some but are not primary cures. Use triage tools like Tinnicare and a concise referral template to get the right care. Final practical actions, one for patients, one for clinicians. For patients, print or save the single paragraph history and present it at your next appointment. If you experience sudden unilateral hearing loss or new severe unilateral tinnitus, go to ENT urgently. For clinicians, adopt the 5-question intake, perform prompt audiometry, test for jaw neck modulation, and make targeted referrals. Avoid blanket, nonspecific recommendations. Closing encouragement and the resource CTA. Tinnitus can be distressing and often feels isolating, but accurate diagnosis and a targeted plan change outcomes. Don't accept learn to live with it as the only answer without first pursuing a focused evaluation. If this video helped clarify what to ask and which specialist to see, the next step is practical. Visit Tinnicare for a downloadable 1-page referral letter and a clinician checklist you can bring to your appointment. Share this video with someone who's been told there's nothing to be done. Many cases improve once the right diagnostic path is followed. If you found this useful, type yes in the comments to let us know you want more clinically practical guides. And if you're a clinician who wants the checklist and referral templates, the Tinnicare link in the description contains a downloadable 1-page referral paragraph, a 3-question clinician checklist, and a quick triage flow you can start using today. You're not alone in this. With focused questions, the right tests, and the proper referrals, many people move from helplessness to tangible improvement. Keep advocating for a diagnostic-first approach. It makes all the difference.